For more than 40 years, HIV has been with us. In the 1980s, it was a death sentence whispered in hospital corridors. In the early 2000s, it was a war fought with ARVs, activism, and grief. Today in 2026, it's a chronic condition, manageable, treatable, and completely controllable. One pill a day can suppress the virus so completely that it cannot be passed on. Which begs the question, so why does stigma still exist today? In 2026, some people still lose jobs, some people lose housing, some people lose relationships the moment they disclose their status. Today we follow the life of a young man from Ukuruleni, Hope Kubega. We find out his story being born with HIV.
I am what you would call an HIV activist, as I was born with it, as someone who understands the struggle, the challenges that come with being HIV positive, because before the education came about, people didn't really understand what this I would say a livelihood, because not a disease, not an illness, it's just a livelihood, something you can actually live with if you comprehend everything that it comes with, the medication and everything. So basically, I was born in 1999. Ever since, I've been living with HIV, and before the introduction of the new regimen, I was introduced to ARVs through those multiple pills that I had to take because of I had to keep my viral load down. So at the time, those pills were just hard for me to swallow because I was just a little kid. I think I was about 4 or 5 years. So having multiple pills to swallow them down, it was kind of a problem. So my doctors and nurses also all suggested that I grind them up and then maybe like take them, just grind it like that. And I kind of did that for some time. It didn't really work well. So with the pills that I had to take, it was really hard for me to swallow because they were all mixed up. 8, I think, of them. I had to grind them up and everything. So, but because of I had a loving and supporting family that kind of took me through everything, I didn't really know what I had until I went to a doctor that I used to attend, because being born with HIV is not as easy as you think. There's a lot of sicknesses, a lot of opportunistic infections, diseases that come to you. So I've been attending that doctor like in every now and then, going to the hospital, coming back, going to the doctor. So the doctor actually told me a story, a very lovely story, and he said, "Do you know what a cat does to a mouse?" I was like, "No, I don't." And he was like, "The cat eats the mouse, and then what happens at home? The house stays safe, no food goes missing and everything." And I was like, "Why are you telling me this?" He was like, these pills that you were taking are the pills, the pills represent that cat, and the mouse is the virus. And I was like, "What virus?" Then it just came out clean. I was like, "It's an HIV virus. You probably have heard of it." Or he was like, do you know Funkosi Johnson?" I was like, "Yeah, I do." And then he was like, "Yeah, that kid, you are that kid." And I was like, "Oh, okay, I understand." So basically from the age of 6 years, I understood why I'm living like this, why I'm taking all these pills every day. And then fast forwarding to my father's passing away, because to be honest, I didn't really know my mother because she died when I was actually 2 months. So my father was there supporting me along with my grandmother and aunt. And then all of them actually were playing a crucial role. My father was a very strict person. He always encouraged me to be a man of me, not a man of another man, just to be like being able to stand up for myself and everything. So in basic fact, what I'm trying to say is that my father was teaching me life before he died. So when I was 9 years old, he was laying on the floor, about to take his last breath, and he called us and said, "You are the man now, because you are the older child. You have to take care of your family no matter what it takes." So it kind of scared me, because now I have to take care of myself, look at these situations that I'm living with, and then now my dad is passing away, telling me that I have the responsibility of taking care of the whole family. Fine. I grew up without a father, without a mother, grandmother was there, my aunt was there every single time. Everything was okay. So in terms of in terms of finances, because okay, finances we were not so good, still not good, and I'm not blaming anyone for that. And finances play a crucial role, especially when you have some sort of disease or illness that you're living with. It plays a role in such a way that you cannot take a medication on an empty stomach. You cannot do a lot of things because, to be honest, this medication, it's improved, yes, but it takes something from your body because if you don't have anything to eat, then it becomes a problem. So, yeah, what I basically say is that HIV, it is not a death sentence, it is not an illness, not a disease, it's a livelihood, something you can live with, something you can comprehend every day. It just takes one pill. Me, now I take my pill every day at 7, my alarm goes off, I'm still in bed. Come on, I'm not working yet, it's fine. I'm still in bed, I'm still sleeping, my alarm goes off, take my pill, it's right there next to me, take my pill, take my water, I'm good. It's just a repeat cycle. You don't have to repeat the whole day like yesterday. You just have to repeat the same thing. Take one pill, take your water, you are done. Go about your life. It's not something you can actually like try to kill yourself over if you find out that you're HIV positive now.
So you know about the stages of acceptance, you know, the grief part. So when you found out and you got to learn about the seriousness of the chronic disease, right? Did you go through that, the stages of acceptance, or you just understood it and just went about your life?
I understood everything. Actually, I understood with the cat and the mouse, like Tom and Jerry. He actually put it in that phrase. So like, yeah, you just have to look at those things and then you're going to be good. So from that age, I didn't really care what was going on. I was just continuing with my regular regimen until I think I was about 10 when I actually understood what it meant. So I didn't really have a grief moment or acceptance. I just accepted when I was younger.
So as you were becoming a teenager, and that's where most people would say being woke comes in, being fully aware of things, and also that's where people start to get into relationships. When it comes to your love life, has that ever affected you to begin with, from being a teenager to being your adult age right now?
Okay. Honestly speaking, I've never let it affect me because every single time I approach someone, the first thing I pop out is, I'm HIV positive. If you are going to accept me, you're going to accept these terms that I'm coming with. So it's never been a problem for me.
So in terms of people who still struggle with acceptance, because as much as now HIV is not as deadly as before, you know, in the early 2000s, it's more maintainable now with each and every ARV that's being produced, right, in order to help combat it. Why do you think some people still struggle with accepting the status? Some people still have that mentality of, if I find out I'm HIV positive, it means I'm dying, it's a death sentence. Why do you think people still have that stigma till this day? It's 2026, but people still have that stigma.
Okay, as much as the Department of Health and other organizations are trying to put out the information and the education out there, a lot of people are not educated in what HIV really is. I see that in my community. When I pop out the fact that I'm HIV positive, they're like, yo, they run away. So they are not well educated. They don't know how you can get infected and how you can get affected by it. So I think it's the lack of education from people. Yeah.
And in closing, what would you like to say to somebody who is not positive but does not really know much about it, or somebody who is positive but is also struggling to just accept and understand that they can still live a normal life?
There's nothing much I can say. Just it is not going away. To be honest, it's not going away. It's not changing anytime soon. It's your life. The sooner you accept it, the sooner you come to terms with the fact that I'm HIV positive. And it also helps to have a supportive figure by your side. Someone who's going to encourage you to take your medication, someone who's going to be there when you go to the clinics and everything. Just have a support buddy and then also coming to terms in your own way to be like, yeah, I'm good. Then for someone who is not HIV positive, you just gotta take your PrEP. Go for regular tests, take your PrEP, make sure that you are well protected. Then you're gonna be good.
Good day, I'm Sister Virginia Williams, an assistant manager at Noctel Angwenya Community Health Center. I'm a professional nurse running the facility. We have 5 different departments of which I am overseeing. Because I'm directly involved in the daily operations of the facility, I'm responsible for ensuring that there's enough staff on duty, ensuring that the daily operations is going well, ensuring that patients are being seen every day, and ensuring that the services is accessible to the community over 24 hours. We currently have a well-established wellness department at Noctel Angwenya. We noticed the need to have a fully fledged team on board to assist nurses that are not coping, including all the other staff, because we don't only have nurses, but because it's nurses, they'll be focusing on nurses. But we have a fully fledged wellness team that assists nurses that are not coping, whether it's emotional stress, physical stress, psychological problems. We have a fully fledged team and that will assist and counsel and provide support. And if we're not able to manage, then we refer to the district level employee assistance program. Nurses are always given an opportunity to access management at any given time. I'm also having an open door policy whereby any staff member can actually come to me at any time to vent or to discuss their frustrations. And then we also make sure that we have the clinic committee, the community on board, so that we have that partnership, that strengthened partnership between us and the community in terms of what they want, what is it that is not working well for them. And we also have complaints, suggestions, and compliments where we encourage those from the community so that we are able to see what is it that the community want from us or that they need, so that we are able to tailor our care to ensure that the community is provided with the care that they need. So for the nurses, yes, there's this general problem with the nurses' attitude. So we do have customer service training where we send nurses to. We also have all other trainings, like sometimes you'll find if there is a challenge with attitude, we need to deal with it. We also need to find out, is it a personal challenge that the nurse is having in her personal life, or is it a problem that is currently created at work? Because sometimes you find attitude can also be created by an over-influx of patients to the facility, and then nurses becomes overwhelmed. And because they come overwhelmed, sometimes you could find that there could be some elements of negative attitude displayed towards the patient. So we ensure that there's coverage, daily coverage, to make sure that there's enough staff on duty. And if there's a shortage of staff, we do call other people to come on duty and to assist with to relieve the current strain on the nurses. At this facility, Noctel Angwenya, we are doing very well in partnering with the community through our clinic committee. We have a very vibrant, active clinic committee that comes to the facility once a week to open complaints boxes, compliment suggestions. We actually view it together with them. And then we go through the complaints that we receive, the suggestions, and we sit down to have a meeting once a month to discuss the challenges that we have, that the community faces, and the challenges that we as the health department faces. The biggest challenge we are currently focusing on, it's the non-adherence of patients to chronic medication. I'm not only focusing on HIV, but also patients that have high blood and that have sugar diabetes. They don't come for their appointments on time. And if they don't come on time, that also causes an over-influx on days when they do come, because we're using a booking system where we want patients to come on the specific date and the specific time that is allocated for them. But some of our patients don't adhere to those dates and to the specific times. So we utilize the clinic committee, we utilize social platforms where we can engage with the clinic committee that can actually filter the message through to our community. We also have health promoters that goes out to the community. We have school health nurses that engages the community. We also have a mobile unit that goes out to the community to render services to hard-to-reach areas for patients that are not able to come to the facility. And then we also share our contact details or contact numbers with patients so that if they're unable to come to the facility, they are able to make the relevant arrangements with our tracer team, which is our WOWO team. So we also do tele-tracing and physical tracing for patients that have not come to the facility. Okay, the message that I would like to convey today is for us to actually work more on strengthening partnerships between ourselves and the community. We want the community to be able to engage us on any platform and to be able to help us, to mold us to become better. Because yes, attitude is a big challenge. It's a big challenge globally, especially in South Africa. You'll always hear patients complaining about nurses' attitude. And lately, we are not even saying it's nurses' attitude, we say staff attitude. Because we're trying to accommodate even the clerk, we're trying to accommodate the cleaner, we're trying to accommodate everybody so that when the patients come to the facility, they have a therapeutic environment.
That side, what I'm doing now as an operational manager is looking after the staff who are taking care of the chronic patients. In terms of chronic patients, what we do there at the department, we are using a booking system. We book them for their dates and times. So the challenges which we are having is the high defaulter rate. Most of the chronic patients, they do default, they don't stick to their booking date and time. So it becomes a challenge. In some days you find that there are many people in one day, which leads to the problem of long waiting time. And you find that maybe the staff is not enough to see those patients because most of them you will find that they are not booked and they are expecting to be seen equivalently with those who are booked. So you find that there is a challenge where you will see that they are saying, the queue is not moving. And then even the staff, when they are overwhelmed, maybe some of them you will find that there is a problem that they are having or because of being overwhelmed, you will find that maybe they are having the misunderstandings with the patients. We do have the strategy. Those maybe who didn't disclose or those who don't want to take their medication, we are having the health promoters in the department, which educates them about the importance of taking their treatment. And also we do the adherence counseling. The clinicians or the sisters, they do adherence counselings to those who are not taking their medication well and to help in disclosure. What we have analyzed is that the rate of not taking the treatment properly or the defaulter rate is high, but we are also having the strategy of going to trace those who have defaulted, because now there is this 1.1 million people who have defaulted in Ekurhuleni, who have defaulted for their treatment. So every Tuesday and Wednesdays and Thursdays, we are having the team which go out and trace the patients who have defaulted and who help them with retaining them to care. Yeah, the response which we are giving, which we are having now, is good, but it's getting there. They do come when they are being traced. They do come. So what I would like to see is that if our clinic committees can have that health talk with the community, and then also include the ward councillor, and then if they can include us in their meetings, so that to encourage the community to come to the clinic, for their treatment. And then for our nurses, what I can say is that we are doing what we can. So let's keep up the spirit and then be what we have been called for. And then we have to, at least, if we are having problems or our attitudes, let's change them so that we can have that trust from the community. To nurses, I can say that, as I said, nurses are doing the good work. So let's keep up doing the good work for the community. Ne? And then to the community, what I can say is that when we come to the facility, let's not come with that thing, yeah, or we expect or nurses are rude or what. In our facility, what I've observed, our nurses, they are not rude, and they do understand. They listen to the story of the patient. So we are having less complaints in our facility and even in our department concerning the staff. There is no that thing of nurses fighting with the patients.
Most patients, for example, with hypertension, they just drink at any time. And there's no consistency on actually having a consistent time that they take the medication. So with that, we have tried to do health education to patients, referring them even to dietitians, involving our health promoters to then promote and educate them about medication. The biggest challenge, I would say, is patients thinking that nurses are rude when they haven't even experienced us. So patients come into our consulting rooms with that mentality that a patient is rude. But once you give the medication and you give the service, then that's when they realize that actually the attitude is not with nurses, it's not with the health profession, but it's actually them receiving knowledge from the community. But the biggest challenge is the attitude between patient and nurses. We do actually have support groups where people that have been recently diagnosed or we see that there's non-compliance, we add them to the groups, and that's where they're educated, they're given more information on the condition that they have, for example, diabetes, hypertension, or ARVs. And as well as with ARVs, we have disclosure or AYFS, where the little kids that have been born with are taught or are given knowledge about the condition that they have and how to live long with it. We actually do have a challenge with people that are being virally unsuppressed. With the current regimen that we are on, which is the dolutegravir, it is stipulated that if a patient takes the medication on a daily, consistently and as prescribed, then the viral load should be lower than detectable. But we are finding cases of high-grade viremia, which is a viral load above 1,000, or even low-grade, which is viral load between 50 and 1,000. And that is due to, as I say, inconsistency in taking medication, and some not having the knowledge that once I have a partner, I'm positive, and the other is positive, then we don't use condom. So it goes back to the health education that we give to them, and they're still not taking that education to its maximum. Okay, I would firstly want to start with the HIV. We have seen an improvement in our total remaining on ARTI, which is TROA, that has improved due to the implementations that have been placed by management of initiating the 1.1 million tracing, where we go out as professionals to go and deliver medication to patients, re-engaging them back into care. And with hypertension and diabetes, we have held the involvement of dietitians where they go there and teach them how to eat healthier. So there is an improvement, though there are still challenges of high blood pressures and uncontrolled diabetes, which we are actively working on. Okay, I would like to start with saying our colleagues, nurses, do not get weary, do not get tired of doing good. When in everything that you do, do it well. Know that the reward will be found in the maker. And let us keep to our pledge and serve the community with utmost respect and dignity. And let us always keep a smile so that they're able to come to us and find the proper care and total quality care that they need. And to our patients, we love you, and we expect that when you come to us, come expecting good service and not with the mentality that we don't love you or we are rude. We are working together. Let us be in partnership and let us work together to achieving total good quality in the healthcare.
The national rollout of lenacapavir was officially launched on June 5th, 2026 at the Lilian Ngoyi Stadium in Secunda, Mpumalanga. The event was led by President Cyril Ramaphosa and attended by Health Minister Aaron Motsoaledi. The launch was specifically for HIV prevention, not for replacing ARVs for people who are already living with HIV.
the launch today of Lenacapavir marks a turning point in our nation's fight against HIV. To us, this incredible treatment is not just a medicine or a drug. To us, it represents a major turning point in South Africa's national story. It represents one of the most significant scientific breakthroughs since the advent of antiretroviral treatment. And as we all know, we are the one country in the world that has carried the heaviest burden of HIV/AIDS. And we are the one country in the world that has had to administer antiretroviral treatment to millions and millions of our people on a daily basis. And we are one country that has had to deploy billions of rands to keep our people alive.